Hello everyone, I am Dr. Arvind Rao H T from Oral Maxillofacial Surgery Department, Yenepoya Dental College. I will be talking on Ludwigs Angina today. These are the student learning objectives. By the end of the session, students are supposed to know the definition of Ludwigs Angina, the etiology of Ludwigs Angina, clinical features, management and complications of the same. These are the contents under which I will be talking. Infection of the orofacial and the neck region has been one of the most common diseases in humans. The condition was first described by Wilhelm Friedrich von Ludwig in 1836. The word angina is derived from the Latin word anger, meaning suffocation or choking sensation. By definition, it is a name given to an overwhelming, massive, firm, browny cellulitis, induration, and acute septic toxic stage involving simultaneously the submandibular, sublingual, and the submental spaces bilaterally. It is a potentially fatal, rapidly expanding and progressive infection involving all the 5 spaces. The etiology most commonly is odontogenic etiology. In 75 to 90% of the cases, it's odontogenic. The causing tooth will be usually the mandibular teeth. So dental caries involving the mandibular teeth has been attributed as one of the most common causes here. Acute dental alveolar abscess, acute periodontal abscess and acute pericoronal abscess from the mandibular teeth has been aspected as the next common causes. The non-odontogenic causes, even though minor, still contribute a significant amount. The traumatic injuries to orofacial regions such as mandibular fractures, trauma to the floor of the mouth, osteomyelitis, submandibular and sublingual sialadenitis, secondary infections and oral malignancies all contribute to this dental disease. Now, pathways of spread. It all depends on the offending tooth. The infected tooth, as I have told before, 75 to 90% of the causes are odontogenic. So the tooth, offending tooth, the apex of the root, if it extends above the mylohyoid in the mandible, then the sublingual space will be infected first, followed by the submandibular space via the posterior border of the mylohyoid muscle along the submandibular salivary gland, then extending anteriorly to the submental space, then contralateral, sublingual and submandibular spaces. If the apex of the offending tooth is below the mylohyoid, then the submandibular space will be infected first, then to the sublingual space via the posterior border of the mylohyoid muscle along the submandibular salivary gland, anterior into the submental space and the contralateral, sublingual and the submandibular space. This picture depicts how infection spreads from the root apex of the mandibular teeth. So if it shows the significance of the attachment of the mylohyoid muscle. So if it's below or above, so it spreads accordingly. If it's above the mylohyoid muscle attachment, it goes to the sublingual. If it's below, it goes to the submandibular and thereby spreads to adjacent spaces as mentioned earlier. The anatomical relations to the involvement of spaces in Ludwigs angina is very significantly depicted in this picture. You can see the way the sublingual space involvement expands or pushes the tongue in the upward direction, thereby causing an obstruction of the airway. So the tongue is pushed upwards and backwards, thereby closing of the airway, leading to airway obstruction, which is pretty fatal unless managed immediately. If left untreated, it can further spread to lateral pharyngeal space, to the retropharyngeal space, danger space and to the mediastinum, leading to mediastinitis. So if this picture you can understand how the infection travels in the backward direction from the sublingual into the lateral pharyngeal spaces by the buccopharyngeal gap, and from there to the retropharyngeal and to the alar space. Alar space, also known as the danger space, has a direct communication with the mediastinum, and thus the infection spreads to mediastinum, causing mediastinitis, which is a very dreaded complication of Ludwigs angina. The clinical features of this condition include patient looking very toxic, ill and dehydrated. Pyrexia, chills and malaise are very common and always occur in this condition. Extraoral examination reveal bilaterally suprahyoid swellings, bony, hard, wood-like, board-like swelling, hard brownie it is termed, and the swelling is usually bilateral and involving submandibular and submental regions. Rise in temperature is also noted in over the swellings. Typically, the mouth remains open due to edema of the sublingual tissues, and tongue may protrude from the mouth because of the elevation of the sublingual space. Intraoral examination reveals swelling which develops rapidly involving sublingual tissues and raises the floor of the mouth. Tongue may be raised against the palate and there may be stiffness in the movement of the tongue. The 3 Ds in Ludwigs angina, the dysarthria, that is difficulty in speech, dysphagia, difficulty in swallowing, dyspnea, shortness of breath. They are typical. See, if you can see in the pictorial, you can clearly assess how it happens. The sublingual space which enlarges, which protrudes the tongue in the backward and posterior region, causes difficulty in speech because of sluggish movement of the tongue. Dysphagia because of inability, the patency of the airway and the patency of the food tract is compromised. So both dyspnea and dysphagia occurs. The diagnostic aids include OPG, lateral view of the mandible, lateral view of the neck, chest X-rays to assess mediastinitis and pleural effusion, ultrasound, CT scan and MRI. The right upper picture indicates the OPG, which is basically to make out the offending tooth. So we have to diagnose the cause. So since 75 to 90% of the causes are odontogenic, so first OPG reveals whether there is an offending tooth. So once that is identified, the lateral view of the mandible and lateral view of the neck both are taken just to assess the spread of infection, the severity of the spread of infection into the supporting surrounding tissues. Ultrasound, since it gives a soft tissue profile, will indicate the amount of spread of the lesion and the pathway of spread, as well as amount of compression on the vital structures. The chest X-rays will give us a diagnosis on the mediastinitis as well as pleural effusion. Computer tomography and magnetic resonance imaging is gold standard for assessing the spread of the infection via the spaces as well as the compression into the vital structures. Management includes three things here: the medical management, the airway management and the surgical management. The medical management, the protocol is the immediate admission. Since it's an emergency condition, the admission has to be done immediately into the hospital. Aggressive IV antibiotic treatment, securement of the airway by tracheostomy if necessary, and drainage of the swelling to reduce pressure. Continuous monitoring of vitals and oxygen saturation has to be done at all times. The medical management include fluid resuscitation, administration of IV antibiotics and analgesics. Antibiotics are advised depending upon the patient's systemic conditions. Initially, after pus collection, empirical antibiotics are given. Later, once the culture and sensitivity is performed, specific antibiotics are advised. Empirical antibiotics indicate that it is an antibiotic given against the anticipated and likely cause of the infectious disease. It is when antimicrobials are given to a person before the specific bacterium or fungus causing the infection are known. So usually broad spectrum antibiotics or bactericidal antibiotics are usually preferred for this. Definitive antibiotic therapy refers to the antibiotic therapy given subsequent to the results of culture and sensitivity, and once you know which organisms has caused and you know exactly what they are susceptible to. So commonly used antibiotics usually is penicillin. Usually the extended spectrum penicillin is preferred. Cephalosporins, nitroimidazole derivatives, aminoglycosides, tetracyclines and macrolides. Airway management is the most important here. The fatality and the mortality of this Ludwigs angina, which makes it the dreaded condition, is because of this airway management compromised. So airway management can be very challenging. The basic management involves decompression of the spaces. Definitive airway management methods include cricothyroidotomy and tracheostomy. Cricothyroidotomy is a simple procedure which is a temporary procedure where an incision is made in the cricothyroid membrane and a tube is slipped into this membrane, thereby bypassing the upper airway and directly getting access to the trachea. But this is a temporary procedure until a definitive endotracheal intubation or tracheostomy can be performed. So it can be life-saving till the definitive management can be attained. Tracheostomy on the other hand is a definitive management where an opening is made into the neck, into the second or the third tracheal ring via vertical emergency incision, and a tube is inserted into the trachea. A wide bore tube is inserted into trachea, bypassing the upper airway where this congestion and the compression is occurring and thereby gaining direct access to the lungs. So this is a tracheostomy picture indicating how the tracheal rings are cut and how the tube is inserted directly into the trachea, bypassing the upper airway and directly getting access to the lungs. The incision drainage is a gold standard for management of Ludwigs angina. So principles are: the patient has to be positioned in the proper supine position, painting and draping has to be done. Incision is made not at the site of maximum fluctuance, but at the site where the dependency is, because these wounds tend to heal with a scar. So when the maximum fluctuance is used, the thin skin will already be atrophic or thinned out, so it will lead to more scarring. Since it happens on the face, scarring should be kept at a minimum and aesthetic becomes a concern. Blunt dissection with the sinus forceps is done. Place a drain and stabilize with sutures. Remove the drain when the drain becomes minimum. Usually a submandibular bilateral incision is placed along with a submental intubation in the midline. This is done for aesthetic purpose. The other older incisions is a cutthroat incision, which is placed from one corner of angle of the mandible to the other across the neck. But since aesthetic is also one of the primary concern, a submandibular incision bilaterally along with a submental or a sublingual incision in the midline is usually preferred. So when these incisions are done, as small incisions, they are dissected out by means of a sinus forceps, breaking all the locules, thereby connecting these incisions across through and through. So care is taken not to spare any locules, making sure all the pus is drained and all the locules are broken and decompression is completed. Once this is done, the drain is placed and secured in position. The purpose of keeping the drain is it allows the discharge of fluids and pus from wound by keeping it patent. The drain allows the debridement of the abscess cavity by irrigation. The removal of the drain depends on the drainage. So it can be removed once the drainage has completely ceased or reduced. It can be left in place for 2 to 3 days, but keeping it more itself can cause infection by being a source of infection. So it's preferred to remove it by 2 to 3 days. The complications of Ludwigs angina include spread of infection to parapharyngeal and retropharyngeal spaces, thereby spreading to mediastinum, causing mediastinitis, which is one of the dreaded complications. Bacteremia, that is the infection spreading into the bloodstream. Septicemia, the infections, the toxins released by the infectious organisms entering the bloodstream. Necrotizing fasciitis, carotid sheath erosion, cavernous sinus thrombosis, meningitis and brain abscess. These are the pictures depicting the various complications, including cavernous sinus thrombosis, brain abscess and meningitis, necrotizing fasciitis, etc. In summary, Ludwigs angina is a life-threatening cellulitis of the soft tissue involving the floor of the mouth and the neck. It involves bilateral compartments of the floor of the mouth, sublingual, submandibular and submental spaces. The infection is rapidly progressive, leading to potential airway obstruction. The most common etiology is a dental infection in the lower molars. Early recognition and treatment, including airway management, aggressive antibiotic therapy and surgical drainage are crucial. These are my references. Thank you.